During our review of respiratory medications that we use for respiratory conditions, we will be focusing on corticosteroids that are used for both COPD and asthma, and non-steroidals that are primarily used in asthma management. Let's look at the role of corticosteroids in respiratory care. As mentioned, inhaled corticosteroids are used in the maintenance of asthma patients who are defined as Step 2 asthmatics. The National Asthma Education and Prevention Program defines Step 2 asthma as symptoms greater than 2 days per week, but not daily, and night awakenings 3 or 4 times per month, with FEV1 or peak flows greater than 80% of predicted value. Corticosteroids are also indicated for COPD as a maintenance therapy. The medications that fall into this category are beclomethasone dipropionate, or QVAR, flonisolide or Aerospan, fluticasone propionate or Flovin, fluticasone furoate or Arnuity ellipta, budesonide or Pulmicort, mometasone or Asmanex, or cisclasenide or Alvesco. Corticosteroids can also be used in combination with LABAs and include fluticasone and salmeterol, which is Advair, budesonide and formoterol, which is Symbicort, mometasone and formoterol, Dulera, and lastly, fluticasone and vilanterol, which is Breo ellipta. As a quick review, the body produces its own corticosteroids, known as endogenous corticosteroids, which regulate metabolism and immune response. When these are produced, the body creates what is known as the HPA axis, which stands for hypothalamic, pituitary, adrenal axis. In this axis, when the hypothalamus is stimulated during stress responses, the hypothalamus sends an impulse to the median eminence, which produces CRF, corticotropin-releasing factor. Then CRF travels to the pituitary, where it releases corticotropin or adrenocorticotropic hormone, ACTH. This hormone stimulates the adrenals to secrete glucocorticoids such as cortisol. Since the body cannot differentiate between endogenous steroids, steroids produced by the body, and exogenous steroids, steroids produced outside the body and given as medication, the body will suppress its own HPA axis, hypothalamus, pituitary, and adrenal suppression, when steroids are administered. To understand how the body tries to defend itself against a foreign invader such as bacteria, allergens, even tobacco smoke, we need to know the 4 categories of the inflammatory response. They are increased vascular permeability, where exudate forms in surrounding tissues, leukocytic infiltration, where the white blood cells migrate through the capillary walls to fight a foreign invader, phagocytosis, where these same white blood cells surround and try to ingest the foreign material, and mediator cascade, which results in histamine and other chemical mediators being released to try to destroy the invader. In the airway, this response may be seen as either early or late phase reactions. For early phase asthmatic reactions, we see increased immunoglobulin E response, IgE. This first phase response is usually bronchoconstriction as a protective response to prevent the invader from moving into the lower airway or alveoli. This is where our bronchodilators are of most use. In late phase response, the mast cell mediators release histamine, cytokines, and recruit other inflammatory cells as a protective response. The problem with this response is that it causes increased mucus production and inflammation in the airway and contributes to increased airway obstruction. This late phase response usually occurs 6 to 8 hours after exposure and can last up to 24 hours. Corticosteroids work on inflammation with 3 general actions of suppression. Number 1, upregulates or increases transcription of anti-inflammatory genes. 2, suppresses factors such as AP-1, which causes transcription of inflammatory genes. Or 3, increases the expression of inhibitors of inflammation such as NF-KB. As a secondary effect, corticosteroids can also restore the responsiveness of beta receptors that have been decreased by overuse of bronchodilators. As a general rule, when steroids are given systemically, they can not only suppress the HPA axis, but may cause immunosuppression, psychiatric disorders, cataract formation, damage to skeletal muscle, peptic ulcers, fluid retention, hypertension, acne, hyperglycemia, and loss of bone density and growth disturbances in children. In topical or aerosol delivery, most of these side effects are minimized. However, the most common side effects in this route of delivery are oral pharyngeal candidiasis, or oral thrush, and dysphonia, or hoarse voice. These side effects can be reduced by using spacers and MDI delivery or having the patient rinse their mouth after administration. Now we will focus on the non-steroidal anti-asthma agents, which can be further divided into 3 classes. Number 1, cromolyn-like drugs or mast cell stabilizers. 2, anti-leukotrienes or anti-LTs. And 3, monoclonal antibodies. Indications for non-steroidal anti-asthma agents are for preventative management of mild persistent asthma and as alternatives to inhaled corticosteroids in step 2 asthma. Anti-LTs may be used in combination with steroids to reduce steroid dose. Understanding of the inflammatory process is important to understanding treatment plans. There are 2 types of asthma, extrinsic and intrinsic. Extrinsic asthma is also called allergic asthma and is triggered by IgE when it attaches to a mast cell and causes the mast cell to burst and releases chemical mediators, causing inflammation. Intrinsic or non-allergic asthma has no known allergen and IgE attachment. Examples are asthma induced by exercise, temperature fluctuations, or stress. As mentioned before, asthma has both an acute and chronic phase, where the acute phase is marked by hyperresponsiveness, leading to bronchoconstriction, and later phase asthma marked by inflammation and mucus plugging. This later phase asthma response with further bronchoconstriction, mucosal swelling, and increased mucus production further leads to airway obstruction that is not relieved by bronchodilators alone. It is in this later response where the mast cell bursts after the second exposure with IgE. This occurs after the second exposure, the allergen or antigen as it is also called. When the mast cell bursts, it releases leukotrienes, prostaglandins, proteases, histamines, platelet activating factor or PAF, and cytokines. These mediators in turn cause the inflammatory response that manifests as vascular leakage, bronchoconstriction, mucus secretion, and mucosal swelling. Also, the release of eosinophils leads to further damage to the airways. The first class we will discuss are the cromolyn, or mast cell stabilizing agents. They are used to prevent an asthma attack from occurring by stabilizing the mast cell and preventing it from bursting in the first place. Examples of this medication are cromolyn sodium and nitochromyl sodium. However, nitochromyl sodium or Tylade has been removed from the market. Side effects of cromolyn include cough, nasal congestion, wheezing and nasal burning, itching, or bleeding, also known as epistaxis. Other uses for cromolyn are for ACE inhibitor-induced cough and reduction in sickle cell production. The next category of nonsteroidal anti-asthma agents are anti-leukotrienes. When the mast cell bursts and spills leukotrienes, the reaction in the bronchi is edema, increased secretions, loss of ciliary activity, and recruitment of other inflammatory cells. The biochemical pathway responsible for this leukotriene production is the 5-lipooxygenase, or 5-LO, pathway. Within the anti-leukotriene agents, we have those that inhibit this 5-LO pathway, those that are leukotriene receptor antagonists, and monoclonal antibodies. We will discuss each in the following slides. An example of a 5-LO inhibitor is Xyluten, marked as Zyflo. It requires monitoring of liver function and may cause headache, abdominal pain, muscle weakness, and indigestion, or dyspepsia. The 2 examples of leukotriene receptor antagonists are Zafreleucist, or Accolade, and Monteleucist, or Singulair. Accolade side effects include headache, increased risk of infection, nausea, diarrhea, and abdominal pain. Singulair side effects include diarrhea, laryngitis, pharyngitis, nausea, otitis, sinusitis, and increased risk of infection. The role of anti-leukotrienes are to protect against specific asthma triggers and are used for chronic persistent asthma. However, it does not necessarily negate the need for corticosteroids in asthma management, as it only works on one pathway of inflammation. Of special concern is the possibility of development of Churg-Strauss syndrome, which is a necrotizing vasculitis that can lead to major organ damage. Advantages of anti-leukotrienes include effectiveness in aspirin sensitivity or exercise-induced asthma, reduction in need for steroids, and they are fairly safe and effective. Disadvantages are there are no long-term studies, so toxicity is unknown, and not everyone responds. Therefore, it is not generally used as the only therapy to treat asthma. Lastly, omalizumab, or Xolair, is also prescribed for uncontrolled moderate to severe asthma. Side effect profile includes injection site reactions, viral infection and upper respiratory infections, pharyngitis, and as an extreme response, anaphylaxis or malignancies. Again, it is used with steroids. As with all anti-asthma medications, monitoring of peak flows are important, and all non-steroidals and corticosteroids are controller, not rescue agents, therefore are not to be used in an acute asthma attack.